All right, looks like we're live. Hi, everyone. I appreciate everyone joining us tonight. We got a really interesting topic. It's a new technique that's really just become available throughout the country when it comes to injecting and doing stem cell procedures for more advanced osteoarthritis. Specifically tonight, we're going to be talking about osteoarthritis of the knee. This technique that we're going to discuss, this intraosseous injection technique, also applies to other joints as well. More severe weight-bearing joints with articular hyaline cartilage, so joints like our hips and our shoulders can also be used with a similar technique. As you can see, it's just me tonight. Dr. Santana had a schedule conflict, so he wasn't able to join live tonight. So he and I pre-recorded a discussion. I like having both of us. I think the give and take, seeing the different perspectives, both he and I, while they're similar, also have slightly different perspectives on how we proceed with our regenerative medicine options and addressing patients. So I think it would be worthwhile for us to go ahead and schedule this, or rather start sharing this pre-recorded discussion he and I had. And then I will be here to answer any questions afterwards. It's about a 15-minute presentation. And if you would like, please do type in your questions on the side. I'll be here and able to type responses as the presentation is going. And then I will jump back on afterwards to answer any questions live as well. So if we're ready, I think we'll go ahead and start sharing our screen. And wonderful.
Good evening, everyone. Dr. John Santana.
Yeah, Dr. Tom Navity, thanks for joining us. Tonight's topic is one that's evolving in our regenerative medicine space. And both Dr. Santana and I wanted to bring this to light as an option for treatment that we're offering now here at Michigan Center of Regenerative Medicine, and discuss reasons why we might consider using what's called interosseous placement of our regenerative medicine product, primarily stem cells, bone marrow concentrate.
Yeah, and I want to say that for the longest time here in this area of Michigan, I want to say we are the most experienced in treating osteoarthritis in the knees with regenerative medicine. I want to say we have the most volume, the most outcomes from patients in this field, and because of that, we're able to kind of keep ahead the competition and abreast with all the leaders in the industry as far as what the technology brings us here. So I would say, Tom, you agree that osteoarthritis in the knees is our most common issue that we see here in the office?
Yeah, it is statistically the number one thing that brings people into the office for us. For the most part, patients have tried most of the conservative treatments and are looking at alternatives to a total knee replacement. So it's a common thing we see as part of the evaluation. We do physical exams, we're going to do ultrasounds, look at any outside imaging you might bring, x-rays or MRIs, and then come up with a treatment plan. And prior to this past year, our treatment plans involved what we had as being the best injection technique available to us, which primarily injected the regenerative products into the joint space, as well as all the structures that support that joint space, so things like ligaments and cartilage. But injected everything from the outside in. And recent literature publications, the society we're most closely affiliated with, the Interventional Orthobiologic Foundation, have really been looking at the pathophysiology, meaning what things look like under a microscope when we're looking at the cartilage in the knee, and maybe coming up with a different injection technique that places those regenerative cells closer to the source of formation of the cartilage that we're trying to regrow.
Yeah. So along those lines, like it's been found on histological studies that the knee joint is actually a really interesting structure. We used to think that when we treat osteoarthritis, we're primarily just addressing the cartilage in that joint space. So the way that we would classically do regenerative medicine or any other treatments for that matter in injections into the joint is to injecting it into that joint space. And the idea is you're trying to reestablish homeostasis in that joint space. Now that we're learning more about regenerative medicine, kind of how the body heals and how the body works, we're starting to see now that the cartilage is not a separate entity from the periosteal bone. So when you look at it on histological slides, the periosteum is actually continuous with the cartilage. And you can even, it makes sense that you can even think about how the cartilage gets its nutrition and nutrients is from the bone itself. So it actually comes up from the bone matrix into the periosteum and then into the cartilage, and how it nourishes that. So it makes sense that if you're treating the cartilage, it's to treat the cartilage itself, but also treat the source of the cartilage where it gets its nutrition and source of life.
So I like analogies. Analogies make the most sense to me, and for me, this is very much like trying to grow leaves on the tree. So we know that those leaves come from the roots and the nutrients that the roots pull out of the ground. So when we're trying to fertilize and get more leaves on our tree, we don't spray the leaves on the outside, but we put that fertilizer into the root, which is essentially the same thing that we're talking about here. That cartilage that's on the end of if you look at the end of your femur or the end of your tibia, which are the two bones that make the hinge joint, that cartilage on the end of both of those bones is growing up from the inside out. And so rather than trying to place the stem cells on the outside and have them penetrate down deeper to stimulate growth of those cartilage cells, placing them actually into the bone at that root source where they're originating from makes a lot more sense pathophysiologically, and then put it into action. And we're seeing that the case for our patients as well.
Interesting enough, like this technique actually evolved from just treating bone marrow lesions, right, that we see on MRI. So you see these subchondral edema on the bone that we see with severe degeneration. Same thing that you see with the hip also. More commonly, it evolves to avascular necrosis or AVN of the hip. So this technique was actually developed to address that. And then knowing more, so now we know the technique to treat these subchondral lesions, then that evolution kind of started like, well, if we're treating this part of the bone and histologically it's related and connected to the cartilage, then theoretically you can address the cartilage by also addressing the bone structure. So it's an exciting field with regenerative medicine because we're learning so much. We're adapting current techniques and expounding on them and learning better ways to treat things, right?
Yeah. So it's as you said, it's an ever-evolving field. These aren't techniques that we had when we first started. But like a lot of things in medicine, when you have a new technique or you have a new innovation that you want to implement, the folks that you tend to do it on first are the ones that you don't think are great candidates. The more advanced diseases, when we talk about knee arthritis, we're looking at things like bone marrow lesions on MRI and X-ray findings, these called KL grading, the more severe or advanced KL grading. And these for folks that in our consults will say, you're more advanced. It's something that's still worthy of trying, but our statistics show that with our previous techniques, our outcomes are not as good as if maybe we had seen you 5 or 10 years earlier. With these interosseous injections, those late-stage patients are doing extremely well.
Yeah. And the nice thing about that too is usually when we see patients with late-stage degeneration where they've already seen the orthopedic surgeon and they've gotten their surgical consults and they've tried physical therapy and the injections before, and they come to us and it becomes a choice between is a knee replacement and surgery option, or should I try this regenerative medicine option and see how the outcome is going to be. Like Dr. Nabity said before, we can pretty much tell patients, like, if you're mild to moderate, your outcomes are going to be good with these regenerative medicine techniques when we're doing it all from intraarticular. Now, with the advent of treating intraosseous as well as intraarticular, you're actually flanking that cartilage on both sides. Then you have I think it improves your prognosis and your likelihood that this is going to work. So even if you are KL grade 3 or 4, which is moderate and severe, then it gives you a chance that this is going to work.
It begs a question in our minds: do we reserve this intraosseous technique really just for those cases that are more severe? that have that more advanced scale grading, or those bone marrow lesions, or those subchondral cysts, those findings that we find on MRIs? Or is this something that, why wouldn't everybody benefit from it? And in my head, I think it makes a lot of sense. So that what are the downsides to doing an intraosseous versus just the particular? A whole lot. It sounds like it's going to be a lot more painful. There's going to be a lot more downtime. While the procedure itself is a bit more painful, it's one that we recommend to be done with anesthesia. The downtime isn't anymore. Our patients are having the exact same 3 to 5 days of some increased soreness, but they're able to walk, they're able to take care of themselves, they're able to do all their activities of daily living. We don't recommend a family vacation or a big gathering where you're going to be on your feet for a long period of time before this procedure, but there really isn't much downtime. There's no surgical recovery, no incisions to be worried about. Everything's done through small needles still.
Yeah. And you think before too, it's been theorized that you're probably going to be non-weight bearing, on these joints, because if you think about it, you're drilling into the bone. But we've done a good number of patients days already, and nobody needed to be on crutches or anything like that, or even braces for that matter. My older patients, I usually tell them, if you're already using a cane or a walker, go ahead and just have that on hand. It's not going to be an instantaneous relief, but so far, as far as function goes, it's not as different as an intra-articular regenerative medicine procedure.
Yeah, it's been a pleasant surprise on how easy our patients have recovered from these, and the procedure itself is technically not a terribly challenging procedure
for us.
Yeah, for well-trained individuals, it's not anything that's more advanced than really what we're already doing. And we have all the equipment here, the necessary equipment. It does require X-ray guidance, whereas the other previous injection technique could all be done under ultrasound guidance.
Right.
So that added equipment, having access to a fluoroscopy X-ray machine, may be technically challenging for some other clinics. Fortunately for us, we already had that for use when we do spines, and some of the other bigger, deeper structures require X-ray guidance. So for us, it's been a very seamless integration of a revolutionary technique, and we've been able to help a lot of patients that previously I think we would have been very reluctant to try a regenerative medicine procedure on, and now we have options for folks who otherwise are looking at a total knee replacement as their only option to gain that function back that they've lost.
Yeah, and I have that dialogue with my patients all the time too, where is patients ask me with severe knee osteoarthritis, what do you think? Should I go through this procedure, or what's the prognosis? And I tell them, what? We have this advanced technique where it is going to give you a better chance than we were able to give you before. But with any severe end-stage disease, there's no guarantees with it. But one thing that I do know, and that we've known and proven many times, is that after the procedure, it's not going to make your symptoms worse, right? At the lowest baseline level, it will do absolutely nothing, but it can improve it significantly as well. Whereas with the surgery, when you have the knee replacement, your treatment options become smaller, because there's really not a lot of tools left after we had a knee replacement if you continue to have pain still. If it goes really well, then that's the outcome that we all want everyone to have. But in that small chance that it doesn't do well, there's really not a lot of options on there. And with regenerative medicine, you still have a lot of options. You're not burning any bridges. You can still have surgery. You can still have additional procedures. You can still have nerve blocks, and it just kind of gives you more options moving forward. So I give that scenario to the patients so they can have that discussion with their families and come up with the best decision for them.
But as far as timeline to getting that benefit, these procedures still take months to regenerate and heal those tissues that have been degraded over time, regenerate cartilage, regrow in cartilage. So I tell patients to plan at least a 3-month timeline before you pass judgment whether this was going to be successful or not. It can take even longer than that, up to 6 months, I would say, would be a normal timeline for growth, but you should see some benefit by that 3-month mark.
Yeah.
We would welcome any questions that you guys might have about this.
Sure.
Our office is doing consults both virtually, telehealth over the phone, as well as in person. We encourage in-person consults whenever possible. It allows us to do a more robust physical exam and do an in-person live ultrasound, which helps us evaluate tissues that sometimes show up well on MRIs, but sometimes don't.
Yeah. So hopefully you guys learned something about this from this episode. If there's other questions, anything specific that you want us to address, please feel free to give us a call or shoot us an email or schedule an appointment here to see either me or Dr. Nabby, and we'll be more than happy to go over your case on an individual basis and come up with the best treatment plan for you.
All right. Thanks for joining us tonight.
Yep. All right.
Take care.
Good night.
All right. Well, thanks, everyone. I hope you enjoyed that video. I appreciate the phone call or the questions that have come in on the chat. Got a couple questions that I still wanted to answer. I was answering as we were going along there. A couple questions about success rates. So one of the things we pride ourselves on here is we do track our outcomes. We used a registry that's being used across the country called Data Biologics. And we can actually compare our outcomes here at Michigan Center of Regenerative Medicine to other clinics around the country. And happy to say that we're as good, if not better, than the other clinics in the procedures they're doing and offering as well. Globally, overall about 70% success rate. Certain things are closer to 90. Other things are closer to 60. And a lot of that has to do with severity of disease. So things like tendons, like rotator cuffs or outside the elbows, lateral epicondylitis, those ones are pretty home runs. I mean, we get very few failures in those, more in the 90th percentile success rates. More severe advanced osteoarthritis of the knee prior to implementing the intraosseous injection techniques was more in the 60th percentile. Now, with very low numbers, we're seeing much higher success rates, closer to that 75 percentile. Spines, kind of the same thing as knees, depends how severe the stenosis is, how severe the disc degeneration is, and really even what's causing your symptoms in the spine, because not all spine conditions have the same cause. Not all are disc problems, not all are ligament problems or pinch nerve problems. So a lot of that's going to depend on the course, or the cause rather, of your pain in your back. Another question coming in about the visco supplements. So things like Orthovisc or Symvisc, Durolane, all common sources of hyaluronic acid injections, which come from egg embryos, chicken egg embryos, and act as basically a barrier, kind of a cushion. In my mind, they help maybe slow some of the degeneration, but they don't lead to any kind of regeneration. So those still can be used in conjunction with regenerative medicine. Most of our patients who have successful regenerative medicine procedures no longer need those, or if they do continue to get them, they get them at a less frequent interval and seem to gain more benefit from them. So great question. I don't incorporate those or mix those into my stem cell or PRP injections for the knee. I know some clinics do. Comparing outcomes from when that's mixed to when it's not hasn't proven to be more beneficial. So I haven't included that as part of the standard that I do. But I've had a couple of patients ask and have no objections to doing that in conjunction with a PRP or a stem cell procedure. Another question about downtime when working on the knees. The downtime is usually very limited. So, and by downtime, I mean doing things that you're not currently doing. So if you're currently, able to walk, able to take care of, going up and down stairs, do your activities of daily living, take care of your household needs. Those aren't problems afterwards. It might have some increased pain for 3 to 5 days, but people are still able to do all those activities. For more advanced activities, maybe you're able to run, but you're running with pain. That's going to get down to the reason why you're having the pain. If it's a meniscus tear, for example, I'm going to tell you to take a month off from running. Now, you can do non-impact exercises, things like running or using an elliptical machine or riding a stationary bike. Those are still options to keep your cardiovascular fitness going and to keep your muscle mass from atrophying. But I would try to avoid that impact for the first month afterwards. Got a question here about the difference between platelet-rich plasma, or PRP, and stem cells. If I had to summarize that difference, we did a webinar on the differences for the different regenerative medicine, but just in a brief answer, the number one word is potency. Both work to stimulate your body to try to heal itself. They do so through slightly different mechanisms. A stem cell procedure uses your body's mesenchymal stem cells, MSCs, which are very powerful signaling cells that tell your native chondrocytes. So those are the cells that make cartilage. So these MSCs tell the chondrocytes to grow, divide, and make more cartilage. Cartilage is all made of collagen, and these cells called fibroblasts are what make your collagen. So a stem cell procedure uses cells called MSCs to stimulate collagen growth. A platelet-rich plasma procedure injects platelets and other growth factors that tell your body to recruit MSCs to the area, and then those MSCs do the same thing. It's really just a numbers game. It's a matter of how many MSCs do we get to the area of injury. And when we do a stem cell procedure, we're getting a lot more MSCs to the injured area than we are when we're doing a platelet-rich plasma procedure. The other big difference is platelet-rich plasma requires a good vascular supply. There has to be a good highway for those stem cells to drive or to get to their end tissues, the tissues that you want to regenerate. So tissues like hyaline cartilage, the cartilage on the end of our weight-bearing joints, like our knee or our hip, those don't have a very good blood supply. So PRP, if we're trying to regenerate that cartilage, it's just not a great option because it doesn't have the potency to get the job done. And another question coming in, are there supplements that we recommend? Yeah, there are. We have a whole host of supplements that we recommend. We're happy to provide that list for you. A lot of them are general supplements that most people take in a regular good multivitamin. But there's also some that are less known. These products called senolytics are probably what I consider to be most important when doing a stem cell procedure. And the two most common of those are called quercetin and fisetin. And essentially they help eliminate the weaker stem cells in our bodies so that when we go do your stem cell extraction, we're only extracting the really strong ones. And I think we have time for maybe one more question here. So it looks like we got a question about the different types of stem cells. Another really good question, do we use your own stem cells or are we using fetal stem cells? A lot of confusion around that topic. So we use only autologous stem cells, so stem cells that are autologous, meaning coming from the patient themselves. Those are the only cells that are legal to use in the United States right now. There are other allogenic type cells that are available in other countries. Things like human umbilical cord cells, human placental cells. I'm not aware of anywhere in the world that's currently using embryonic cells, human embryonic cells. So ethical reasons aside, human embryonic cells, while being studied vastly in the late 90s and early 2000s, all the research, to my knowledge, has gone to the wayside because none of those cells really were able to just generate very specific tissues that we're looking for with things like regenerative medicine for orthopedic issues. For example, you'd try to grow a cartilage and you might get hair growing or some other abnormal growth, non-cancerous, but tumors called teratomas. And so for the most part, all of that research in embryonic cells has gone to the side. Big question now is whether things like umbilical cord cells or placental cells are superior to your own bone marrow or fat-derived MSC, mesenchymal stem cells. Using these registries like what we're using here, encouraging clinics around the world outside our country to use that same registry so we can compare outcomes and really see if there's a big difference in those or not. In my opinion, and what I've seen so far, I haven't noticed a profound difference in those patients who have chosen to go to, say, the Cayman Islands or chosen to go to Cancun or to Panama, and those that have treated with me. In fact, I have had a handful of patients who have flown elsewhere and had different types of allogenic stem cells injected, didn't work, and then came in and had theirs done here with us, and they end up working. So I would say really getting a good outcome is three variables. Number one is selecting the right patient, having the right diagnosis, and injecting the right location. You know, if you're having a shoulder pain because you have a pinched nerve in your neck and I inject your shoulder, well, it's probably not going to work because your problem's in your neck. So step one is proper diagnosis, knowing what the right structure is to treat. Step two is being really good about injecting those cells directly into the diagnosed structure. So using ultrasound, using X-ray, and having skills to drive that needle. Dr. Santana in our presentation earlier made the comment that, you know, for well-skilled physicians, this new intraosseous technique is not that difficult, but for someone who doesn't have those needle skills, I'm sure it's quite a challenge. So you want to make sure you're going to somebody who knows how to put a needle in the right spot. And then the third variable is using the right product, and that's the question that essentially you're posing is a umbilical cord cell better? Is a placental cell better? Or are my cells just as good, if not better, because they're being used in me? And using that registry and tracking outcomes is really going to answer that question for us. I think I've probably taken enough time for everyone. I really appreciate everyone logging in, participating in the live event. We'll have the replay available, sent out if you have friends or family that missed this and you think would be interested in listening to it. By all means, please share it with them. And then any of you that are interested, please give us a call. We're in Rochester, Michigan, 248-216-1008. Happy to do virtual consults or in person if you're local. So again, thanks for tuning in, and we'll see you next month. Bye.